My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening and welcome to the latest in the BOFAS series of Lectures of Distinction. My name is Callum Clark. I'm one of the members of the BOFAS Education Committee. And just a couple of housekeeping points before we go get on with the webinar. If you want to post some questions and answers, and please do, we have plenty of time in this webinar after our speaker to answer the questions, and we will do. So put them in the question and answer section, please, at the bottom of your screen. Secondly, in terms of getting your certificate for attendance, if you respond to the link which will be sent to you to fill in a feedback form, then your certificate will follow shortly after that. So on with the webinar, we're going to be talking about tendon transfers in the foot and ankle. And we've got an excellent speaker, Mr. Nick Cullen, who's someone I've known for, well, over 20 years now, Nick, I think, and who's an excellent surgeon and is a consultant at the Royal National Orthopaedic Hospital, Stanmore, with a great deal of experience in this topic. So I'll hand over to you now, please, Nick.
Thanks very much, Callum. Okay, so plantigrade foot. We're going to talk about the principles of tendon transfers, the indications, how we assess for a tendon transfer, and talk about some of the more common foot and ankle tendon transfers, but we're not going to be exhaustive. We'll finish off with some rehabilitation tips. So what are our considerations when we're thinking about a patient who may possibly benefit from a tendon transfer? There's a lot to think about and a lot of considerations. So it's quite a complex area. We're going to talk about the MRC grade of muscles, the concept of phasic and non-phasic muscles. We're going to talk about the line of action of muscle pull, the excursion of the muscle bellies, what joints they're traversing. We'll talk a bit about the tendon tunnel, the insertion points, donor site morbidity, tensioning, balancing, and pull-out strength, which are all really key to a successful tendon transfer. It's interesting to look at the relative muscle strengths of the muscles around the foot and ankle. And the Achilles tendon is way above the muscle strengths of all the other tendons. So, 10 times higher than most of them. If we look, probably next up is the tibialis anterior, which is 10 times less strong than the Achilles tendon, the tibialis posterior tendon, and the peroneus longus, which is actually stronger than the brevis. And if we look at the extensor digitorum longus, then that is actually stronger than the EHL, but the flexor hallucis longus is stronger than the flexor digitorum longus. So it's interesting when we're considering transferring a tendon, it's good to know what the relative strengths of these tendons are. When we're thinking of transferring a tendon, we must first of all understand where the tendon passes relative to the ankle or hindfoot joints that we're aiming to control. As well as that, the distance that the tendon acts from the center of rotation of that joint will have a bearing on what lever arm they have and how strong that action will be. It's also helpful to think about force couples. So in the normal foot and ankle, muscles tend to act as force couples. And there's a synergy between these, which is carefully balanced between the agonists and the antagonists. So we can see that some muscles are contracting and eccentrically, and some are concentrically to control the range of movement and the movement through that joint. If one of these force couples becomes paralyzed, then the antagonist will dominate. And this is what results in the deformity through the axis of the joints that they cross. Examples of force couples are the gastrocsoleus and the tibialis anterior muscle. And when these fail, for example, the tibialis anterior weakness with a rupture, we'll end up with an equinus deformity at the ankle that they act across. If there's gastrocsoleus weakness, as in the case of a number of polio patients, then this will result in a true cavus. Other examples of force couples are the tibialis posterior and the peroneal tendons. So with a weak tibialis posterior, we see commonly that patients present with a valgus heel and an everted foot. Whereas if there's a weak peroneal tendon, we can have a varus heel and an inverted foot. And things become more complex when we have, for example, neurological injuries with a proximal peroneal nerve injury, where there are multiple muscle groups across both ankle and hindfoot involved. This concept of phasic and non-phasic muscle groups. So a phasic muscle is one that acts in the same direction across a joint. So examples of these are the EHL tendon and the tibialis anterior, which both pass anterior to the axis of the ankle and act as dorsiflexors. And then there are the non-phasic muscles. So for example, the tibialis posterior tendon passes posterior to the axis of the ankle and is a flexor or a plantar flexor. And this is not an extensor, so it's a non-phasic muscle. So wherever possible in tendon transfers in the foot and ankle, trying to look for a phasic transfer is preferable. Non-phasic muscle transfers tend to lose at least one MRC grade of power, whereas the phasic muscles tend to lose less strength and they need less re-education because they're doing the same job. Another concept is the vector of action. So tendon transfers that have acute multiple direction changes will necessarily reduce the efficiency of their action. So a muscular tendinous orientation in one vector is preferable and optimal because that will reduce in less wastage of strength. Examples of this are the peroneus longus transfer. So in patients with a tibialis anterior weakness where you elect to do a peroneus longus tendon transfer, you can either go circumferentially around the fibula or in the interosseous plane. Because the peroneus longus is attached very laterally over the fibula, there's quite a direct vector of pull if this is transferred anteriorly in the circumferential route. But if it's passed in the interosseous, there tends to be a change in direction and there's a weaker strength of pull. The similar thing could happen with the tibialis posterior, because we can do a circumferential transfer over the anterior aspect of the tibia, and we can go in the interosseous plane. But when you look at this transfer, if you're attaching it to tibialis anterior, then the vector looks to be pretty much similar on both, so it's less important. Fashioning of the tendon tunnel. Well, your options are either to go very deep to the retinaculum, or you can go subcutaneous. There are probably some advantages of going deep. Sometimes that can improve the lever arm and the retinaculum can act as a pulley, and sometimes that can improve the muscle excursion. But as a general rule, we tend to use a subcutaneous transfer. This allows adequate excursion of the muscle. It doesn't overpack the retinaculum, and it provides a much more optimal vector of action. And there's usually good smooth tunneling in the subcutaneous plane through the flat fat, so there's less tethering. Whenever we think about tendon transfers, we have to think about the primary deformity within foot and ankle. If there is deformity there, then very often this will need to be corrected. The first question to ask is, actually, is this deformity flexible? If we have a stiff, rigid cavus hindfoot, then trying to transfer tendons where there's no fulcrum or hinge is going to be pointless because there is no joint to act over. If there is deformity, is this correctable? If it's not correctable, how are we going to manage to correct that deformity in order to get a tendon transfer acting over a reasonably physiologically aligned joint? So, for example, with an equinus deformity of the ankle, we may need to consider an Achilles tendon lengthening in order to get the foot up to plantigrade to do a tendon transfer over the front to improve dorsiflexion. If there's bony deformity, we may need to consider a calcaneal osteotomy or a dorsiflexion osteotomy of the first ray in the cavus foot in this picture. And in those patients with fixed deformity, we may need to consider doing a corrective fusion. So if this was fixed, we may need to consider a corrective triple arthrodesis. And even with the triple arthrodesis, it doesn't negate the need in a number of cases to perform an associated tendon transfer, because if there's an imbalance, it's still going to act over that fusion mass. What about the timing? Well, ideally, if we're going to do tendon transfers, we want to do them while the hind foot or the ankle is still flexible. And to a degree, we've missed the boat if we get to the ankle once the fixed deformity is set in. With regards to neurological injury, recovery can take up to a year and beyond. So if we're seeing improvement, it's well worth waiting this out to see what the final result of weakness is so that we can predict our tendon transfers a bit more efficiently. The history is important, with a lot of weaknesses in deformities, working out what the onset was, whether there's history of trauma, family history of neurological conditions or similar deformity, trying to work out where the weakness is. Is it just isolated to the lower limb or elsewhere? What were the changes of weakness over time? Has the deformity progressed? And if so, how rapidly and how has it progressed? Working out what the functional restrictions of the patient actually are and what treatments, splints have they had to date, what surgeries have they had to date. It's also important to find out what the patient expectations are. So if you have a patient who's had a significant sciatic or peroneal nerve injury, and you're thinking of having tendon transfers to improve a bit of dorsiflexion, if they're expecting to get back to their Argentinian tango classes, we're going to end up with tears. Clinical examination. So as we've said, you need to assess the deformity, and I tend to try and take a logical approach, and we look at deformity segmentally. So reducing the ankle, is the ankle reducible? and then reducing the ankle and seeing where the hindfoot lies. If the hindfoot is flexible, reducing the hindfoot and seeing what deformity is uncovered in the forefoot. So we reduce the hindfoot to talar neutral or the heel to physiological valgus. And once we've tested flexibility and deformity, we need to assess power. And I think a really good practice, and what I tend to do, is to make a note of all of the muscle groups and what their relative powers are, whether there's weakness or not. And that's for both the potential donor tendons and also the recipient tendon. Is it completely paralyzed or is it just a little weak? So we've got a couple of slides here. This is a video of and if you bend your knee up, a examination of an ankle. This patient had Friedreich's ataxia, and we can see she's beautifully flexible, but her ankle is in fixed equinus. We're reducing her back to talar neutral, and as we do that, you'll see that the plantar flex first ray here is uncovered, and there's marked clawing of all the lesser toes. Your foot up against my hand. You can see that there's markedly weak dorsiflexion. I may be able to overcome that with just my finger. And then you can see, looking at the toes here, these are being recruited. So the phasic muscles of EDL and EHL are being recruited and lifting the ankle upwards. We can see that I'm pointing out that the tendons are working and functioning well. Everters, very weak. So the peroneal tendons I'm able to overcome with my thumb. Push in against my hand. And the tibialis posterior is very good power. I'm not able really to overcome that. When we talk about the tibia, examining the tibialis posterior tendon, this is the my foot, and we can see that the foot's, we're testing this in an inverted position, so the foot's inverted, and the tibialis anterior is coming into play. So we can't really assess tib post. But when we put in the plantar flexed and everted position, the tibialis anterior lever arm becomes less, and we can isolate the tibialis posterior tendon. So always assess the tib post in a plantar flexed everted position. Investigations. I think investigations are quite helpful in the planning of a tendon transfer. X-rays or weight-bearing CT scans are helpful to assess deformity, arthritic changes within the joints, and what might need to be done to get that foot into a plantigrade position. MRI scans can tell us both arthritis, integrity of tendons, muscle wasting, denervation. I think electrophysiology, certainly in the neurological setting, can be really helpful to work out what's denervated and what's not. And with our cavus feet, we tend to have patients undergo genetic testing to see what subvariant of CMT they have, which can have some bearing on the progression of the disease. What about rehabilitation? So post-operatively, we need to protect the repair. The repair, whether this is buried in a bone tunnel or whether it's attached to another tendon, takes a while for these to strengthen up, and we're relying on our fixation for these to pull out. So we tend to protect the foot and ankle in a plaster of Paris initially to let the wounds heal up. If possible, if there's no associated bony procedures, I tend to try and transfer them into a boot at 2 weeks. And this will allow a passive range of movement within the safe range and some isotonic contraction of your tendon transfer. It takes about 6 weeks if you're using a bony tunnel to get the Sharpie's fibers to begin joining and join the interface. So in a bone to tendon transfer, then this needs to be, the foot really needs to be protected up to 6 weeks. It's really important after any tendon transfer to undergo functional rehabilitation. And we tend to start allowing concentric and eccentric strengthening from 6 weeks. It's much easier to do this when we have a phasic transfer, because most of these tendons are doing a job that they've always done. And sometimes we'll use a functional electrical stimulation to try and help some of the more superficial muscles to start firing and use it for biofeedback. So I'm going to talk a little bit about some of the more common tendon transfers. So we start off with a situation that we frequently see, which is a chronic Achilles tendon rupture. And we're left often with a situation that we have with the bottom picture here. Once we've debrided that scarred up Achilles tendon, we're left with quite a sizable gap. Our options really are for an avascular interposition tendon graft or to consider a tendon transfer. Ideally, we look at our muscle power chart here, and we can see that all of the muscles seem to be working other than the Achilles tendon. But the phasic muscles that we could use are the tibialis posterior, the peroneals, the FHL or the FDL. All of them have got good vectors of action. All of them, like the Achilles tendon, acts as primary plantar flexors. In this case, what comes into play is the donor site morbidity. The tibialis posterior and the peroneal tendons will act as significant force couples into inversion and eversion of the hindfoot, and donating one of these will have an effect on hindfoot movement. The EDL is a potential, but this is half as strong as the as the FHL tendon. So the bonuses of the FHL tendon, which we most frequently see for Achilles tendon ruptures, are that it's a phasic muscle. It's got a really similar vector of action. There's a low donor site morbidity. The vascularity from the low-lying muscle belly is really helpful because we can see that it's a relatively delicate wound at the back, often over revision surgery, and having a muscle belly there helps with vascularity and if there are any wound issues. We tend to insert it into the calcaneum or even the distal Achilles tendon remnant if it looks good quality and it's there. And we can either do a short suture, a short harvest or a long harvest. Personally, for a chronic rupture of the Achilles tendon, I try to do a long harvest if possible, because I think this allows us to bring back the tendon and attach it back onto the proximal Achilles and the proximal calf, which means that not only is this a tendon transfer, but it acts to a degree as a vascularized interposition graft as well. So this is the situation. We're looking at a very big defect, and we tend to pull down the FHL is right underneath that deep fascia below the Achilles tendon. And we harvest it up. You can see the big thick muscle belly here lying deep. The plantaris is still intact. What we've done here, and these are from the Orthopaedic from Mark Heron's website, which is fantastic. We've passed it through the distal Achilles tendon stump, and you can see there's a drill hole here passed through the calcaneum. So we're taking advantage of both a tendon to tendon repair and a bony repair with an interference screw. It's important with the FHL tendon transfers to have a reasonable tension, but not to over tension these. It's quite easy to over tension them. And this is a short graft, not a long graft. Moving on to the adult acquired flat foot, which is one of the most common tendon transfers that we come across. So again, it's very important with the adult acquired flat foot to achieve a bony correction. We often do this with a medializing calcaneal osteotomy to correct the heel valgus. With a very abducted foot, we might consider a lateral column lengthening. And in a number of cases, we may need to do a cotton osteotomy so that we restore the tripod of the foot. Then we look at what muscles we have and we decide what is most appropriate to transfer. So again, it's only the tibialis posterior tendon that's weak here. And we've got a multitude of tendons that we could select. But the two phasic tendons to go with tibialis posterior are either the FHL or the FDL. And those pass right by. They act as both plantar flexors at the ankle and they act as inverters of the hindfoot. All of the other muscles that are available there are non-phasic muscles, and they're going to lose power and they're going to be much more difficult to train up. The alternative here is the Cobb tibialis anterior to posterior tenodesis. So a lot of people prefer the Cobb procedure. This involves taking a 1/3 slip of the tibialis anterior, and it's divided proximally above the superior retinaculum, and it's passed down towards the insertion of tibialis anterior, is brought through and sutured to the proximal remnant of the tendon of tibialis posterior, so proximal to the tendinosis. Once it's sutured, the tibialis anterior is snapped back behind the medial malleolus and the retinaculum is repaired over it. So this is really a vascularized interposition graft. The alternative, which is the repair that I tend to favour, is the FDL transfer. I tend to perform the FDL as opposed to the FHL. I know that the FHL is twice as strong as the FDL, but I think the FHL has a much more important role in the functioning of that first ray. So the FDL has a less donor site morbidity, and I think it's less missed. And what we tend to do is we can see here that we've repaired the spring ligament, which has got a huge rent in it, and a drill hole is passed through the navicular. The FDL tendon is whip stitched, and some strong fibre wire sutures are passed here through the tendon. And then those are passed up from a plantar to dorsal direction through the navicular and tightened. And we can see the sutures passing plantar here to dorsal through the navicular. Question is how tight do we put these in? And there are various muscle strain curves that you can look at, and sometimes in the lab the optimal tensions are not to maximal tension. I tend to find with the foot and ankle tendons that there's always a degree of creep in the tendon, and I tend to put these in quite firmly. When performing a tendon transfer, I tend to try and put the foot in a reduced optimal position of inversion, and I tend to put a firm tightening force on, and then use a biotenodesis or an interference screw with the tendon in the bony tunnel. But I always tend to suture that tendon to the periosteum as well, as I think an interference screw with this degree of force, there is a pull-out rate. What about tendon transfers in pes cavus? Well, again, in pes cavus, we need to assess the bony deformity. We need to assess whether this is fixed or flexible. And if it's partially correctable, what is the residual deformity? What happens when we reduce the hind foot? Do we uncover significant forefoot deformity? And very often in the cavus foot, we'll need to correct this deformity, whether it be by calcaneal osteotomies, dorsiflexion osteotomies of the first ray, sometimes a wedge tarsectomy, and in those fixed deformities, even a triple fusion. With the pes cavus deformities that come to surgery, there's often significant neurological weakness, and that can be quite variable. Commonly, the Achilles tendon is relatively preserved. The tibialis posterior tendon is relatively preserved. The FHL and FDL can be preserved. The tibialis and the extensor hallucis and digitorum are sometimes preserved, sometimes not. We could see in that lady who we did the examination for that she had preserved. The tibialis anterior is almost always weak. Peroneus brevis is almost always weak, and the peroneus longus is usually weak, but maybe not as weak as the peroneus brevis. The phasic muscles here are the EHL and the EDL for tibialis anterior and for dorsiflexion. So the bread and butter for pes cavus is to consider a tibialis posterior tendon transfer. So the tib post acts as a plantar flexor at the ankle and an inverter at the hind foot. And it's often the primary deforming force in pes cavus, pulling the hind foot into and the heel into inversion. We tend to take the tibialis posterior off its insertion and pass it through to the lateral border of the foot, or the superior or the dorsal border of the foot. So you can see here the tibialis posterior is taken on a proximally based stump and it's whip stitched again. The tib post can be transferred it needs to be transferred to reduce the hind foot, and it can be put in various places. My preference with the tibialis posterior tendon transfer is to attach this to the peroneus brevis tendon. Why to the peroneus brevis? What we're trying to do is achieve the maximal lever arm for eversion. And the tibialis posterior tendon transfer is going to act over the hind foot. So adding it to the peroneus brevis tendon is going to be the most lateral point. So we're going to give it the best lever arm as an everter. When it's passed through the interosseous membrane, it's important to develop enough space within that interosseous membrane so that the tendon glides properly. And you can temporarily wrap the tendon round the peroneus brevis tendon to see what deformity you're left with. On occasions when we do this, the foot everts too much and we'll have to elect a more medial insertion point. And we can put that through drill holes of into the cuboid or the lateral cuneiform, the intermediate cuneiform. But I think we've got to think hard about the tendon transfers as well, because whilst transferring the tibialis posterior tendon alone can be really effective in some of the milder cases, for more severe deformity, and sometimes we're still left with residual deformity. So it's helpful with tendon transfers to think what else we can use. With the tibialis posterior tendon transfer that's primarily used to correct the inversion of the hind foot, we can still be left with a significant foot drop. And in those patients, can we think about other tendons that might be phasic that we could use to transfer? So this is the importance of testing every muscle that you have in your foot. So this is a case where we had a strong recruiting EHL and EDL tendons with a significant foot drop. And what we've done here is we've transferred those tendons onto tibialis anterior. When we transfer it to tibialis anterior, as we stitch these in, we make sure that the equinus deformity is completely corrected and the foot is brought up into a plantigrade or slightly dorsiflex position while it's sutured on. And you can see here, we've managed to suture this onto tibialis anterior, and we've managed to achieve very good tension in this tibialis anterior. You can see here as well, we've done a dorsiflexion osteotomy of the first ray, and we've done an IP joint fusion of the hallux. Problem here is we've tensioned the tibialis anterior up, but the foot is fundamentally imbalanced in this pes cavus foot because we've got an inverted hind foot. So the patient's not going to be happy, whereas we've addressed the deformity across the ankle, we haven't addressed the couple across the hind foot. And in this patient, we've taken the tibialis posterior tendon and we've passed this laterally through the interosseous membrane, and we're going to attach this to the peroneus brevis tendon. So the superficial peroneal nerve is at risk here, so it's important to develop this tunnel in a blunt fashion. And now we've put that tibialis posterior tendon into the peroneus brevis, we can see that the foot looks nicely balanced. We've got a plantigrade foot, and we've corrected that hind foot varus. You can see that we've done the fusions of the PIP joints here, which is something I've tended to tend towards, as I think this is helpful to get the balance of the flexors and extensors right. And I think this helps offload the plantar fascia, which is often under tension. So again, that's what we look like with a well-balanced foot. So this is the case that we saw earlier of the neurological foot with a strong tibialis posterior, strong EHL tendons, and this is the patient that we've just looked at now with the tendon transfers. So this is her walking in the clinic beforehand. You can see that she actually couldn't walk without her shoes because she was so imbalanced, and these gave her some stability with the orthotics in. This was the...
That's it.
This is the same patient a year after the tendon transfers. So she can balance on her feet without her shoes. She can even make a little jump. I think the Argentinian tango is beyond her, but we've managed to have a much more plantigrade stable foot. The next big section, or one of the last big sections, are the tendon transfers for foot drop. So again, let's go back to our little chart to look at what's working and what's not. And in foot drop, this can be variable. You know, foot drops can be caused by a tibialis anterior pathology. It can be caused by any number of neurological injuries, and often the patterns vary significantly. We usually have a strong Achilles. We usually have a strong tib post. FHL and FDL are strong. Peroneus brevis and peroneus longus might be affected, might not be. The tibialis anterior is usually affected, and the EHL and the EDL maybe, maybe not. And again, the EHL and the EDL are the phasic muscles for tibialis anterior. So the non-phasic muscles are tib post, and these can be transferred circumferentially or in the interosseous pattern, the peroneal tendons, and the FHL and the FDL. So ideally, if we can transfer the phasic muscles, this is preferable. And we can see here, this is the tibialis posterior tendon transfer, which is frequently used when the EHL and the EDL aren't strong enough. And these can be transferred on the right through a circumferential route subcutaneously and attached onto the tibialis anterior, or if the peroneal tendons are paralyzed, more laterally. And the interosseous is seen on the other side, where things are passed through the interosseous membrane and then down through to the top of the foot. So what about the insertion point? Well, we have to work out whether the what muscles are weak here. If this is a pure tibialis anterior weakness, then we can consider transferring our tibialis posterior onto the tibant itself. If the peroneals are very weak as well, inserting it purely to the tibialis anterior is going to invert the hind foot, and we need to transfer this either more laterally into the intermediate or lateral cuneiform. And the reason for doing that is so that we get some dorsiflexion moment at the ankle, but also we're not inverting the foot. And the other option here is the bridle procedure that we'll talk about. So this is the bridle procedure, or a modified bridle procedure. If we've got, tends to be used when we've got a foot drop with peroneal weakness. You can see here the tibialis posterior tendon has been passed through an interosseous path, and it's put into the tibialis anterior, again, with the foot in a dorsiflexed position. The problem with tightening the tibialis posterior up to the tibialis anterior is it will tension the tibialis anterior and cause an inversion of the hind foot. As the peroneal tendons are very, very weak, what we tend to do is have a distally based peroneus longus tendon, a distally based peroneus longus tendon. So we divide this proximally. We stitch the brevis onto the longus to transfer any power that we have, and then transfer that in a subcutaneous fashion up onto the tibialis anterior and the tibialis posterior. And what this does is allow that tibialis posterior tendon to act both through the tibant and through the peroneals. And the tendons are tensioned up appropriately until the foot looks plantigrade. A couple more rare conditions are the tendon transfers for peroneal tendon disruption. We can use grafts and use silicone spacers to create a tunnel to repair these peroneal tendons. The alternatives are using the flexor tendons. The flexor digitorum longus, again, is phasic in terms of it's an ankle plantarflexion, but it's non-phasic in terms of the fact it's an inverter of the hind foot and not an everter. But it can be passed around the posterior aspect of the tibia, around the posterior fibula, into the peroneal groove and down to the lateral border of the foot. It's got a reasonably straight vector of pull. There we go. So take-home messages. It's a complex situation when we're talking about tendon transfers in the foot and ankle. It's fundamental to tendon transfers that we have to assess and have joint flexibility, that we have to correct underlying deformity. I think it's really good practice to assess each and every muscle unit in the foot and ankle and document those so that we know what's strong, what's weak, what's potentially transferable. It's important to take on this concept of a phasic muscle. And if we can recruit a muscle that's doing a similar job to the one we're transferring for, they're going to do better. It's easier to recruit. They lose less strength. Try and put your tendon in a direct vector rather than going round the houses and winding it round acute angles. We tend to use a subcutaneous path rather than deep to the retinaculum. Once we put the tendon in, it's really important to balance that foot and get the tendon into an isometric point, you could call it. So the foot is neither inverted, everted, dorsiflexed or plantarflexed. When you're tensioning the tendons, try and reduce the foot into the position you want while you're tensioning. You need to protect that repair afterwards, so you don't allow too much tension to go through before your Sharpie's fibers have developed between the bone or tendon. And intensive rehabilitation after these tendon transfers is key. A little bit of extra reading if anybody's interested. I found these papers really helpful and thought-provoking. So those will be on the website. Thanks very much.
Well, thanks very much, Nick. That was an incredible description and a tour through what is a really complicated topic. I think everybody finds this subject very difficult, and you've given a really logical approach to it. So thank you very much. We've got some questions, and I think just a general one to start with. I mean, and just also to remind people to use the Q&A box, because we will get to those. Just a general one about selecting patients, Nick. Obviously, these are big procedures. But how important is selection of patients in terms of selecting your procedure? So, for example, when would you perhaps opt for a hindfoot fusion in a patient who had an otherwise mobile foot? Is that important to you?
I think it's very important, patient selection, and I think the keys are working out what the aspirations of the patient are, what they're looking to do. And I think with some of these tendon transfers, they will achieve a certain amount, but then they may not achieve the degree of function that the patient wants. And so sometimes you will be better off with an arthrodesis to get the foot into a functional position rather than a tendon transfer. So with all things, and especially with tendon transfers, trying to get the patient's aspirations aligned with what you can do is really important. So there are certain things. Yeah, I think in the neurological situation, so in those patients with pes cavus and those patients with profound weakness, I think flexibility is really important. So I think weakness and stiffness are bad fellows. And if you can maintain flexibility and maintain coordination around a joint with flexibility, that is preferable. And I think once we start to fuse multiple joints in the neurologically weak, it can cause them to be very unstable and very unbalanced. So in the neurological setting, I would try and preserve joints where I possibly can. Sorry, Callum, I think you're muted there.
Sorry, along the same lines, Nick, what about prehabilitation? You mentioned FES earlier on. Do you ever use this preoperatively or any other prehab techniques?
I think it's really helpful. I think sometimes trying to get access to prehabilitation is difficult, but I think that is optimal. And I think sometimes you get the really switched on patients, and you can say that we're going to transfer your flexor digitorum longus tendon, or we're going to transfer your tibialis posterior tendon. And if you can get the physiotherapist there isolating that tendon and knowing what they're functioning, if they can use FES and get those muscle units functioning, then I think they find it much easier post-operatively to do that. And the really motivated patients can actually start to build up those muscles that are being transferred before they actually go for a tendon transfer.
Yeah.
But sometimes with these tendon transfers, I think the concept of what we're doing is quite difficult. And I would say it's a majority of patients will find it very difficult to understand what we're talking about when we are trying to strengthen up a functional unit and where we're putting it. So I think in those selected patients who know what's going on, have a good functional awareness of their body, I think it's great.
Well, we've got a whole string of, as you might expect with a topic like this, of very specific technical questions. I don't think we're going to get through them all because there are so many different operations, but perhaps just a sort of a fairly general specific one about, you mentioned about subcutaneous transfer of tendons, which you seem to favour. Have you had any problems with bowstringing with that sort of technique?
So most of these are for cavus feet. You do have prominent tendons over the top of the foot. I don't think that tends to be too much of a problem in the neurological setting at all. I do find probably more of an issue than the bowstringing is the repair. Sometimes you can get a bulky repair, especially around the peroneal tendons, where when you're repairing it, trying to wrap that repair around the tendon, try and make it less bulky is important. So specifically, I don't think the bowstringing is a big issue in the neurological feet. In the non-neurological conditions, we don't tend to use a subcutaneous tunnel as much. It's really those tendons that we're transferring through the interosseous membrane or around the front of the tibia or fibula that tend to be subcutaneous.
Yeah. And what about inserting, plugging in these tendon transfers? Obviously, you've got your different techniques. What techniques do you have for reducing the risk of pullout when you're using interference screws, for example?
So I think the world is split, and this is a heated debate, isn't it? But personally, if possible, I tend to prefer a tendon-to-tendon transfer where I can, and we are limited by those tendons that we can attach. So in the pes cavus situation, I tend to find most of the time a transfer to the peroneal tendons gives me an optimal lever arm, and I think you can get a number of good stitches between the peroneals and the tib post, and I think the pull-out strength is very good. I have had a few, I think it's a real problem, Callum, with the pullouts from the Tenodesis screws when you've got a strong tendon acting in a direct vector. And I've had a few pullouts where people have done well for a while, and then the tendon has popped, far down the line, probably 6 months and beyond. So I tend not to trust just a pure Tenodesis screw. And what I tend to do is, if I'm using a Tenodesis screw, I'll also use either some anchors or I'll use some periosteal stitches to the tendon while it goes in. So I'd probably call that a belt and braces technique. I haven't had any experience myself of using buttons, and I know some people will use a button to try and flip that onto the sole of the foot, deep to that, something I haven't used myself. But I would say, in my experience, if I'm going to use a Tenodesis screw, I'll use that and something else. Okay.
Right, some quick fire specific ones then, I think. So what about peroneus brevis transfer to peroneus longus in idiopathic peroneal spastic flat foot?
Yeah, but that's something that I have not any experience of. I think this is probably something that we see more in the pediatric population than in the adult flat population, because in the adult population, I don't think I can remember something that has ultimately ended up in a spastic flat foot like that. So it's something I've got little experience of. I think that'll probably be more something that's dealt with more in the pediatric population. So I'm sorry, I can't help you with that.
Yeah, that's fine. And do you favour in a neurological drop foot, which you have covered off, in a flat foot, would you recommend still a tib post transfer, even though the patient has a flat foot, or do you have experience with tenodesis of tib ant to the distal tibia? So I think that's a leading question.
Yeah, but I think you've got to be very careful with a flat foot. I think with the tenodesis, my experience, I've seen stress fractures of the tibia, and I think with the tenodesis, they almost always stretch out. So you may get a reasonable result to start off with the tenodesis, but they tend to stretch out and they're not functional. So I don't think it's very good at resisting foot drop. If you have a situation where you've got a flat foot and a foot drop, I think we might need to consider doing something like a flat foot correction and consider doing a tibialis posterior at the same time if the tib post is functioning. So what we may need to do is consider a calcaneal osteotomy if it's a very flat foot. If there's a spring ligament problem, repairing that, possibly doing an FDL tendon transfer like we would normally, and then putting the tibialis posterior onto the tibialis anterior.
Yeah. I think there's a couple of questions which really are more like the sorts of questions that should be asked in a case conference. So I don't think we'll go into those, but I have a question for you, Nick. You were talking about pes cavus and predominantly neuromuscular pes cavus. Do you use tendon transfers in sort of physiological pes cavus cases? So the sort of failing cavus foot with the lateral structures failing?
Rarely. So I think, Callum, again, it goes down to assessing the muscle power in the agonists and antagonists. And if I can't find any demonstrable weakness in the antagonists and agonists and antagonists, then I'd be reluctant to do a tendon transfer. I might do a calcaneal osteotomy or correct the foot, dorsiflexion osteotomy of the first ray. But if I can't find any demonstrable weakness, I tend to be reluctant to do tendon transfers. There's always exceptions to the rule, but as a rule, that's something I'd try and steer clear of. Yeah.
And then also, you mentioned about forced couples earlier on. Do you use tenotomies of antagonist muscles at all in the setting of neuromuscular? So you might tenotomize one muscle, say, for example, the tibialis posterior, at the same time as doing a transfer of another.
It's something that you could consider doing. Historically, what we used to do was do a tibialis posterior tendon lengthening. And my thought process now is that if we've got a good, useful tendon, tenotomizing that may not be the best use for that tendon. So if we can use that for a useful other situation and transfer it somewhere else, would that not be optimal than just lengthening that tendon? However, there are some of these, in the situation where we may have the chronic equinus foot, then with fixed toe flexion, then doing tenotomies of the toe tendons where there's a degree of contracture or something by themselves seems to be a reasonable thing to do. And in those patients who might have quite severe neurological deformity and very poor skin quality, then sometimes a tenotomy will allow us to get that foot round and in order to simply brace the foot better.
Yeah.
So that's the equinovarus deformity where you've got a really tight tibialis posterior, for example, and doing a big tendon transfer may be a bit too much for what that skin will involve or how the patient could recover from that. So there is a place for it, but I'll try and use that tendon rather than tenotomize it if possible.
Yeah. Well, I think that wraps it up, Nick. We've had a lot of questions, but we've run out of time. We could have had more. So thank you very much once again for an excellent talk and for fielding all those difficult questions. To the attendees, we will message you with the link for your feedback, and then your certificate of attendance will follow from that. Thank you to all of you as well, and thank you to our sponsors. So to finish with, we'll have another video from our sponsors, Ramsey Health. So thank you, everybody, and good night.